Okay, hello and welcome everyone. So in this video, I'm going to talk about managed care, and it's managed with the goal of trying to reduce costs. That's why care would be managed. Basically, the idea would be, let's try to have some organization with oversight and information at the population level that's going to be able to use this to rein in costs. So for example, we have the Health Maintenance Organization, the HMO. It'd be a version of a prepaid group practice used to try to control cost, meaning there'd be some contract for the group that's covered whereby the medical providers that are included in the HMO are agreeing to provide treatment for some fixed capitated payment. Capitation, it's the fixed fee, it's a fixed prepaid amount that's given in advance for everything, all the necessary treatments for some defined group. And I've noted here, these are the paid in advance for all the necessary treatments that have been anticipated on the basis of population data, right? And so ultimately this is to contrast with a standard fee-for-service delivery mechanism as a way to kind of control costs. Now, an economist looking at this as immediately can see how the incentive structure has changed. Now, if the medical providers have some fixed amount that's got to last for whatever is the duration of the contract, let's say on an annual basis for the group, they're going to think really carefully about how to conserve that lump sum. Because what the medical providers are going to walk away with is whatever is left after all the necessary treatments have been administered, right? And so this is going to, at the physician, at the provider, at the administration level, create the scope for some really important choices and trade-offs in terms of trying to come up with, well, what's the most cost-effective treatment? There's also scope for different types of problems. Remember, there is the problem of moral hazard that can enter. Moral hazard is a problem that happens after the transaction, whereby those who are then in the action role might very well operate in an opportunistic fashion. In other words, so the worst reading of this would be the physicians and the medical providers might try to restrict how much medical service is being administered to be able to protect whatever remains from this fixed sum. So that would be the sort of like one of the sort of worst case criticisms of the policy. On the other hand, it's sort of like where the scope for cost savings can come from. This is in contrast from the standard fee-for-service delivery mechanism where you'd show up, you'd administer the service, and then be paid and reimbursed for whatever had been administered. Whoops. So managed care is essentially offering a basic collection of cheap, lower cost options that hopefully, will be satisfactory for the people who are then being funneled toward them. So the idea is, you have a whole collection of treatment options, a whole collection of options available. And the idea is, hopefully the lowest cost versions are going to be satisfactory for most conditions. And then you have some oversight. You have a gatekeeper who's looking to see, okay, on a limited basis, for those who really need it, we'll funnel those individuals towards the more expensive options. The idea is to have some type of access limited by a gatekeeper. This can be requiring referrals to see specialists and so on and so forth, having different types of oversight in terms of approving hospital stays or extended duration of stays or whatever. And there's a whole variety of managed care organizational structures such as point-of-service, POS plans, consumer-directed health plans, CDHPs, HMOs, which could be a group model, could be a staff model, could be a network model, and independent practice associations. So that comes in a variety of forms, some of which might have more or fewer of the problems that I mentioned. The basic idea is, managed care is going to try to control costs through a couple of different practices that we'll kind of characterize as selective contracting, risk-sharing agreements, and utilization review. So selective contracting, there's a couple different forms. There could be closed panel. So we'd contract with the structure would be a closed panel for which medical providers are able to contract with the organization. In this case, patients would be restricted to some specific network and not allowed to choose outside of the network. And the payments would only, the capitated payments would go only to those network providers, of course, and then there wouldn't be any funds for those out of network. Any willing provider would be if you have a situation where actually any medical provider could agree to join the network for whatever is going to be the covered group and then receive the payment, but then have to administer the necessary treatments. In terms of risk sharing agreements, well, so we had this aspect where the contracts with, for instance, the primary care physician for whatever is this fixed capitated payment is determined in advance, and now the medical provider bears the risk, right? So this is inherently what's behind some of the opportunistic behavior that could potentially be available, which is like, okay, you've got this fixed amount for this group of patients, and on the one hand, if their cost of treatment exceeds whatever is this fixed fee, then that's the risk that the primary care or the physician is bearing. On the other hand, we realize for some individuals it will. For some individuals are going to be more costly on average than others, and for some it won't. For some individuals, the cost of treatment will be much less. On average, hopefully the capitated payment matches the average cost of an individual, or is actually like more than the average cost of treating an individual, so that the physician comes out with at least some profits. But anyway, what ends up happening is that this is shifting some of the risk away from the system, and then from the managed care organization and onto the medical providers themselves. The idea then would be, hopefully then the medical providers are sufficiently incentivized to be themselves good gatekeepers of administering the care. On the standard fee for service arrangement, what would happen is the provider just potentially would recommend and perform services following whatever is the pattern of reimbursement. So now you've got a different problem of moral hazard, which is that, well, if some treatments have more lucrative reimbursements or some particular courses of treatment, now you've got an incentive to follow that pattern instead. And so there's moral hazard actually throughout the healthcare system. It could happen with a standard fee for service. It could happen in a different way for our managed care. Basic idea is this type of prepayment mechanism associated with managed care ends up shifting the incentive toward lower cost treatments instead of towards higher cost treatments, which, if we're looking from the standpoint of society and the healthcare system as a whole, might very well be more desirable, other things equal. The last aspect is the utilization review. So there's typically some type of authorization review, second opinion, case management that's involved, especially with hospital stays. The idea here, specific for hospital stays, is there might be some type of oversight before the treatment or at the time that the hospital stay is being approved. There might be some type of second opinion that's required before surgery is granted to see how, have we treated all similar cases like this, what's the standard of care, so on and so forth. And then case management then monitors the resources that are being used to lower the overall costs throughout the duration of the treatment. And then sometimes some of these aspects are backward looking to inform practices for the future.